Hello everyone, and welcome to the new topic on principles of biopsy and histopathology reporting. If you look through the playlists on oral pathology or oral pathology, oral medicine, or ODSS1, you will notice that this topic has been discussed previously. So the only difference here is the new set of learning outcomes for the DTS curriculum and a couple of slides. So let's look forward. Right, so the learning outcomes for this topic are that by the end of this topic, you should be able to explain the principles of surgery for biopsy procedures, number one, and number two is you should be able to explain the techniques of biopsy, including indications, contraindications, potential complications, patient care, and patient education. So both the previous lectures as well as these lectures both this lecture are the same, and as I mentioned, the only difference is the learning outcome. Right. So the first question that comes to our mind when we talk of biopsy is, what is biopsy? I'm sure you have an idea of what it is, but in terms of description, it is the removal of tissue from a living organism for the purpose of microscopic examination and diagnosis. Right. So basically, it's the removal of living tissue. Right. Removal of living tissue for the purpose of microscopic examination and diagnosis. So why submit a biopsy? So the answer to that is to establish a definitive histopathological diagnosis. That means whenever you are in doubt in terms of the clinical diagnosis, you want to confirm the diagnosis, the final diagnosis is always the histopathological diagnosis. The second is to confirm a provisional clinical diagnosis. That means you have come up with a working diagnosis and you want to confirm whether it is that or anything else. Clinical and pathological correlation. Okay, to be able to correlate the clinical and pathological aspects of disease, we do a biopsy. And lastly, to provide diagnostic information to a clinician for the management of disease. Right. So this is the most important aspect, because diagnosis of a particular lesion determines the treatment outcome. Okay. So establishing definitive final diagnosis in order to be able to plan suitable treatment for our patients is the aim because of which we do biopsies. Right. So the next question is, what are the types of biopsies? Right. So broadly, biopsies are categorized into incisional biopsies and excisional biopsies. All right. The word incisional is used when you have a large lesion and you take a small piece for diagnosis. That's when you use the word incisional. Okay. So let me give you an example. For example, let's say there is a very big lesion here, right? And we want to know what this lesion is. Then we actually take a small piece of this tissue, okay, and examine it. And this small piece that's taken from a big large lesion is called incisional biopsies. All right. Excisional biopsies, on the other hand, are basically done for smaller lesions. That means lesions that are less than 2 centimeters. All right, less than 2 centimeters. So they're basically smaller lesions, and so you are able to take out the whole thing in one sitting. That is when you call it an excisional biopsy. Right. So the rule of thumb is any lesion that is less than 2 centimeters, okay, you do an excisional biopsy. Anything that is larger than 2 centimeters, you do an incisional biopsy. Right. So the reasons are quite logical here, because it's smaller in size, you can take it out in one sitting, and you're pretty much sure that the smaller lesion is probably benign, all right, less dangerous, and we do not see any complication in removing the whole lesion together. Whereas in a larger lesion like the one here, okay, diagrammatically represented, you're not sure what this could be. You cannot take it out in one sitting because it could lead to severe bleeding on the dental chair, and so you decide to actually take it. Okay, so this is a picture from my days of training, wherein a lady who was 65-year-old came to the dental office with a large ulcerative lesion on the lip, extending from the lower lip right onto the left side of the upper lip. So this is a huge large lesion, right? So to confirm diagnosis here, okay, we would have to do take a small piece of tissue, right? So you probably would take it from multiple sites to be able to confirm it. But when you do take small piece of tissue from a large lesion, you actually it clearly becomes a case where you do incisional biopsy. Okay, so this is where a clear indication of incisional biopsy, of a case where we do incisional biopsies. Whereas on the other side, you have this lesion here, which is a growth, right? A growth on the gingiva, a small pedunculated growth, okay, well loculated, and is less than 2 centimeter in size, and so it is clearly indicative of an excisional biopsy. That means we can take this whole lesion out in one surgical sitting, okay, right? So this is how you differentiate cases where you actually need to do incisional biopsies or excisional biopsies. Okay, further on, if we look at the types of biopsies under incision biopsies, they are categorized based on the basically broadly the instrument that is actually used. Okay, basically the instrument that is used. So if we look at it, number one, we have scalpel biopsy, you have punch biopsy, we have brush biopsy where they use a brush, you have scrape biopsy where they scrape out the mucosal surface, right? When bone is taken, it's called incisional, it's called bone biopsy. FNAB, right? The word FNAB is the abbreviation FNAB stands for fine needle aspiration biopsy. Okay, so we will look into it as we go through this lecture. And lastly is frozen section. Okay, so these are different examples of incisional biopsies. Okay, that means large lesions, you take a smaller piece. So when you take it using a scalpel, you call it scalpel biopsy. Punch, when you use a punch. Brush, when you use a brush, and so on and so forth. And we will look into it as we go through further this lecture. Right, so this is a picture of some scalpels that are used by oral surgeons and dental surgeons to do biopsies in the oral cavity. This is a picture of a punch, right? So a punch is pretty much like a ballpoint pen, right? So it has a handle, it has a hub and a blade, all right? So what happens is you push this blade down through the mucosal surface or through the lesion, and then the piece of tissue gets collected in this piece in the blade in the blade, and this is used for histopathological diagnosis, right? So we will look into it as we go and discuss each biopsy procedure in this lecture. Okay, this is an example of brush, right? So this is oral brush, okay, a circular brush which is used to scrape cells of the mucosa. All right, so this is an example of brush biopsy. Right, now this is an example of excisional biopsy. Okay, so if you look here, this is a partially resected mandible. Okay, so there was a growth that was clinically present, and it was diagnosed as a tumor. Okay, it was diagnosed as a tumor on incisional biopsy, and the treatment that was indicated was resection. Right, so partial mandible has been resected. If you look at it, this is the mandible here. These are the teeth over here. Right, this is the tumor, and these are surrounding muscles and other structures. Okay, so this is an example of excisional biopsy, and if you look at it, this is uh, a table where on these biopsies are actually studied. We do something called as grossing to be able to again section them and further study them and come up with our final diagnosis. Okay, right. So let's look at some general guidelines for oral mucosal biopsies. Okay, so mucosal biopsies are one among the most common biopsies that are done in dental offices. So first of all, we always need to be aware of regional anatomy. That means you need to be aware of the nerves, the blood vessels, any important structures that are present in the vicinity of the lesion. Then we select the worst looking area for the biopsy. Okay, we anesthetize around the lesion rather than directly into the lesion. Okay, the reason we do not anesthetize directly into the lesion is because when you inject anesthetic liquid into the lesion, it leads to distortion of cells, which can lead to microscopic misdiagnosis, okay, which can lead to microscopic misdiagnosis, right? So biopsy, as we study here, is very important in terms of technique, okay. So in terms of technique, it's very important. We need to make sure that we are aware of the regional anatomy. We need to take care of the worst looking area for the biopsy so that we come up with the correct representative area that needs to be diagnosed, and then we need to anesthetize around the lesion, okay. With incisional biopsies, it may be helpful to obtain minimal normal adjacent mucosa, right? So as I had actually drawn, okay, in the previous slide, for a larger lesion, you would actually prefer to actually take normal plus lesional tissue for diagnosis, okay. So this is the lesional tissue here, okay, and this is the normal tissue, okay. This is the normal tissue, okay. This is done in order so that we will be able to compare between the lesional tissue as well as the normal tissue, and in many cases wherein we want to know which is the cell of origin in terms of this lesion, is very important to keep this rule in mind. Right, next is we avoid biopsying the center of an ulcer or a necrotic area, okay. So what does that mean? Okay, it means that if you have a large ulcerative lesion here, you do not take the biopsy from the central necrotic area. You do not take it from here. The reason we don't take it from the necrotic area is because if you take it from the necrotic area, the cells that you will see would be the dead necrotic cells, and we will not be able to come up with a histological diagnosis, a histopathological diagnosis, right? So the right place to take the biopsy would be, as mentioned in the previous statement, that is including 1/3 of normal and including the the abnormal tissue, okay, and not the necrotic center, okay. The next important guideline is avoid crushing the specimen with forceps, right? So for the procedure for biopsy, there is an armamentarium wherein we use forceps to hold the piece of tissue before you actually detach it from the mucosa, okay. So at that time, it's very important that the operator or the assistant should not use excessive amount of force with the forceps and crush the specimen. Again, what goes wrong with using additional force and crushing it is that the cells get distorted, and that could lead to a microscopic misdiagnosis, right? Lastly is hemostasis with pressure and a suture, okay. We must use pressure and suture. We must avoid using suction, right, when we're doing a biopsy procedure, because many a times when you're doing mucosal biopsies and you overuse suction, then again it leads to an artifact, or it leads to a microscopic misdiagnosis because of distortion of cells, right? Okay, so let's now look at the first type of incisional biopsy, which is scalpel biopsy. Let's look at its advantages. So we call it scalpel biopsy when you use a scalpel, as I showed you, right? So advantages is, first of all, you're able to control. You have control over the size and the depth of the specimen, okay? Because based on the size of the lesion, you are able to determine how big a biopsy you need, because it's using a scalpel which is directly is under your control, okay. This biopsy is acceptable for both freely movable, that is soft palate, floor of the mouth, and bound down tissues such as gingiva and hard palate as well, okay. So it may produce a more satisfactory specimen without excess tissue, such as in punch biopsy, all right. The drawback is that it is more technique sensitive. That means if you are not trained, if you do not keep in mind the guidelines that we just discussed while doing this biopsy procedure, then it can lead to uh, unnecessary use of this technique, or wrong specimen, or wrong representative tissue, right? Okay, so for the armamentarium, you need first of all we need local anesthesia, number 15 blade, forceps, scissors, suture and needle, a needle holder, and sterile gauze. Okay, so Okay, so let's look at this case example here. So we have this patient who has actually come to us with a white patch, which is a homogeneous leukoplakia affecting the right lateral and the ventral areas of the tongue. Okay, so if you look at this, this is a homogeneous patch. Then you have here, which is a whitish patch and a slightly reddish area here. So these are the steps that are actually done in before in the process of taking a scalpel biopsy. Okay, so this is a clear case of indicated for scalpel biopsy. So the first step is you've identified the lesion, you've identified the site. Okay, so you give the second step is picture B, wherein there is an infiltration being given around the lesion. All right, the third step C and D is where um, an elliptical incision is being traced and is done using the scalpel. An elliptical incision is given around the lesion. All right. Thereafter, the anterior edge of the ellipse is gently raised with a tissue forceps, which allows the detachment of the ellipse-shaped tissue. Okay, and once that's detached, you use the scissors and cut it out and detach it from the mucosa, and then the biopsy is taken. So that piece of tissue is immediately put into um, the specimen container, which has 10% formalin in it, and the raw area that is actually present is then sutured up. Okay, so this is the steps that are followed in um, scalpel biopsy. Okay, so now let's look at punch biopsy, right? So when you use the device called punch, then you call it a punch biopsy. The advantages are, first of all, ease of technique. Sutures may not be required if a small diameter punch is used, and it may produce a more satisfactory specimen in bound down tissues. Okay, especially for example the lesions that are on the hard palate. Okay, so the drawbacks, however, may be that the specimen may not be adequate for deeper pathologies because it is restricted by the depth of the blade. Okay, and it may be difficult to biopsy freely movable tissues, for example the soft palate and frozen mouth. Okay, right, so this is the armamentarium for punch biopsy. So this is here the punch that we have. Okay, this is the punch. Right now, this is a very beautiful photograph, a diagrammatic representation that I've found, and I love to discuss this with my students always. So here, actually, if you look at this diagram carefully, you have the hands of the operator with the punch here. Okay, so this is the handle, this is the hub, and this is the blade. So here, they are actually trying to biopsy the pigmented lesion on the skin, right? So if you look at, this is the lesion that they're trying to biopsy. Now if you look at the left right corner, then it shows you a zoomed in view of the operator, wherein the diameter of the punch is involving normal tissue as well as the pigmented piece of tissue. Okay, so while you decide the site of biopsy, the location of the biopsy, you are technically picturizing what you intend to biopsy. So if you look at the upper left corner, then you are actually seeing that the blades are actually going through normal tissue as well as abnormal tissue, which is actually the aim of uh, doing a biopsy right. Okay, and if you look at this picture diagram carefully, you will also note that the depth of the biopsy is determined by the depth of the blade. Okay, which is a drawback in some cases of the punch, and in some cases it is an advantage as well. Okay, so a punch biopsy is a very good type of biopsy for skin lesions, for pigmented lesions in the oral cavity. They are best suitable for lesions on the hard palate. Okay, right. Okay, so let's now look at the third type of biopsy procedure, which is called as exfoliative cytology. Alright, the word exfoliative cytology and brush biopsy are actually used pretty much interchangeably. Okay, so basically what we do here is basically surface mucosal epithelial cells are scraped off. Okay, are scraped off. So when you're actually basically epithelial cells in the mucosa actually exfoliate uh, once they mature. Okay, and the aim of this type of biopsy is to basically examine those cells that can that exfoliate or that can be scraped off under the microscope to be able to determine if there is any underlying pathology. Okay, so here you're actually seeing a brush that is used to scrape out cells, and here you're actually seeing a wooden spatula that is actually used to scrape out cells. Okay, so the procedure is pretty much simple. Basically, once you have scraped the cells from off the mucosa, you actually spread it onto a glass slide. All right, you basically roll the brush over, or you spread it using the spatula, and then you use a spray fixative. Okay, and dry the slide, and then transport it to the lab wherein they stain it, and they stain it, and then they examine it microscopically, and they are able to tell you if the morphology of the cells is normal or abnormal. Okay, so this is an example of a non-invasive procedure. Patients are very much willing to get it done. It's indicated in cases where you're not able to do a scalpel biopsy, or the patient is not willing to do it. You also use this procedure as a screening tool. Okay, as a screening tool to screen patients who have uh, precancerous lesions. Okay, precancerous lesions. All right, let's look at brush biopsy now. All right, so brush biopsy, brush biopsy and exfoliative cytology, as I mentioned, basically are interchangeably kind of used, but there are specific brush biopsy kits that are actually available in the market, which are actually patented and are actually marketed as tools that have very high specificity and sensitivity in terms of diagnosis. And one such example is actually oral CTX. Now, oral CTX, I like to discuss it here for with students here is because it is one of those brush biopsy techniques wherein the biopsy is done using a kit which comes from the lab, from the oral CTX lab, and once you do the smear, you send it back to the lab, which is based in the US, and then they use technology. Okay, they use technology to basically scan through the slides using advanced technology to be able to detect abnormal cells. Okay, and I'll show you how an example of the report. And because it is done automated, there is a very high degree of sensitivity and specificity of this diagnosis. Okay, all right, so oral CTX is a type of brush biopsy to test benign appearing common white or red spots that would not have been selected for biopsy. Okay, so the brush basically looks like this, and its indications are invasive biopsy where invasive biopsies are not suitable. There's a lack of patient acceptance, lesions that require long-term histological follow-up. Multiple successive invasive biopsies are not practical. Okay, these are important indications where you would want to do oral CTX. Advantage is ease of the technique. It's non-invasive, as I told you. Patient acceptance is very good. So the drawbacks are lack of tissue architecture. Okay, obviously cannot appreciate tissue architecture because these are cytologies. That means two-dimensional images or two-dimensional visualization of a three-dimensional structure. Okay, so basically we're scraping the cells, epithelial cells, putting them flat onto a glass slide, and then we're trying to visualize them. So we're not able to see the association of those epithelial cells with fellow epithelial cells as part of the tissue. Okay, that's what this means. Reactive changes may mimic atypical changes on interpretation. Okay, so this is one of the drawbacks. That means if you are actually going to do a brush biopsy of an inflammatory lesion, then generally the inflammation can mimic like a malignancy, and obviously you need experienced pathologists to be able to distinguish that. Okay, it's not useful for the diagnosis of pigmented or connective tissue lesions. Okay, that is one of the drawbacks of brush biopsy. Okay, so this is the diagrammatic representation. So basically the brush is scraped onto the epithelial cell on the mucosa, and the mucosa here is showing cells that have different sizes of nuclei, that are different grades of chromatism, so all indicative of abnormality in the epithelium. All right, and then these cells basically get attached to the bristles over here, and when you these cells get attached to the bristles over here, and when you actually spread it onto the glass slide, these cells appear flattened out like that. However, despite they being appear flattened out, we are okay. So the brush biopsy kit comes as something like this. Okay, it has a pre-coded glass slide and a matching coded test requisition form, alcohol fixative, pre-addressed container for submitting contents. So all you have to do is to identify the site, rotate the brush on the lesion to be to collect the sample, then spread the cells on the glass slide. Okay, spread the fixative, pour the fixative, and let it dry. And then you actually send it off to the lab, and the lab, after interpretation using automated um, algorithms, okay, using algorithms, computerized algorithms, comes up with images of abnormal cells as well as measurements of the nuclear cytoplasmic ratio, the nuclear diameter, and various other parameters that are indicative of atypia. Atypia means abnormality of the epithelial cells. Okay, so for those of you who are not familiar, all epithelial cells, before they become malignant, they always undergo something called as atypical changes. That means changes which indicate that the cell is going to turn dysplastic or has turned dysplastic and has a high chance of turning into cancer. Okay, so as we progress through the ODSS course, we will be going through this furthermore in detail. So the aim here basically is that as a dental surgeon tomorrow, when you identify these suspicious lesions in the oral cavity, it is important to do a brush biopsy so that you are monitoring these lesions and we are able to give our patients an early diagnosis. Okay, our success as a dental surgeons in the management, in the awareness of oral cancer, is to be able to detect cancer early, not to detect cancer late, and that can only be done if we keep an eye of suspicion on oral lesions and do brush biopsies um, to be able to identify if there is any atypical changes that are taking place. Okay, all right, so this is basically oral CDX. Okay, now these are actually images of lesions, okay, as we discussed in the previous slides, which are not suitable for brush biopsy. Okay, so these are two pigmented lesions on the mucosa, and this is a connective tissue growth. Okay, so we cannot do a brush biopsy because you will not be able to get representative tissue to be able to come up with a diagnosis. Okay, so this brings us to the end of the first part of my lecture on brush biopsy. Next week I will be discussing other biopsy techniques as well as the importance in terms of um, biopsy requisition filling out. Okay, so thank you very much. Good morning, everyone. So this is the second lecture in the series on the topic of biopsy. So last week we had discussed what is biopsy, types of biopsy, and in details about incisional biopsy, scalpel biopsy, punch biopsy, brush biopsy, and this week we will discuss FNAC, frozen section, and what tissue needs to be submitted to biopsy. All right, so when we look at the terminology FNAC, okay, it stands for fine needle aspiration cytology or fine needle aspiration biopsy. So I'll tell you what exactly is the difference between the two. Alright, now this biopsy procedure is done for swellings. Alright, please remember this is done only for swellings. Okay, so these swellings could be on the head and neck, could be intraoral, mostly is done for extraoral swelling. So here you can see that there is a swelling here on the neck, all right, a very localized swelling, a well-defined swelling here. And in these cases, when you want to actually identify or come up with a diagnosis, what you can do here is a procedure called fine needle aspiration cytology, or FNAC. Okay, now the basic difference between FNAC and FNAB is basically if you use a fine gauge needle, a finer, thinner gauge needle, then you call it an FNAC. But if you use a wider bore needle to collect tissue instead of cells alone, then you call it fine needle aspiration biopsy. Okay. Okay, so now this is the FNAC armamentarium. Uh, so as I just mentioned, these are the various types of needles that can be used for a fine needle aspiration. Right on top here is a tissue core biopsy needle. Okay, and these needles here are finer needles. So as I mentioned on the previous slide, when you use finer needles, you call it an FNAC. If you use a broad gauge needle like the needle here on top, then it becomes a biopsy. That's because when you use a finer needle, you're actually collecting cells, individual cells. But when you use a wide bore needle like the needle here, it actually collects tissue. All right, or that's why it's called a fine needle aspiration biopsy. So for a fine needle aspiration biopsy, we use a tissue core biopsy needle, whereas for a fine needle aspiration cytology, you use finer needles. All right. In addition to this, what else do we need? Right. So we have a kit like this, all right, wherein you have the syringe, the needle, you have the holder here, okay, which comes as a kit. Okay, you have the microscope obviously to examine the slide, you have a fixer, you have glass slides, and these are the processing liquids for basically staining the slide. Okay, so this is also called a mobile FNAC card, because once you do the procedure, you actually immediately prepare the slide and then you fix it, stain it, and you can observe it. Right, procedure. Okay, so I'm first going to run you through the steps of the procedure, and then I'm going to show you the pictures of how it's actually done. Okay, so first step is that, as I told you, we do it for swellings. So if we have an extraoral swelling, then you localize and stabilize the mass, okay, with your fingers, and with the other hand you insert. The next step is the insertion of the needle into the swelling. Okay, the step after that is aspiration of the contents of the mass in different directions. I'm going to show you how that's done. Okay, and next step is withdrawal of the needle. That means after you've aspirated, you withdraw the needle. And last step is you transfer the material from the needle onto a glass slide to prepare the smear. Okay, so these are the basic steps. So localization, stabilization, insertion of the needle, aspiration of the contents, withdrawal of the needle, and then transfer of material from the needle onto a smear. Now, as I show you on the next slide, how important is this step here? All right, that means after aspiration, when you're withdrawing the needle from the lesion and transferring the material is among the most important steps, or rather, this is what makes it a very technique sensitive biopsy technique. Okay, so I will explain to you in the following slides. Right, so for easy understanding, these are pictures from a textbook. All right, and here the image that is shown is that of a fruit, an orange, very commonly available fruit. And when you say localization and stabilization, this is what it means. Basically, you hold your finger, you use your hand to stabilize the lesion so that it doesn't move during the procedure. Okay, the second step, as we had just discussed, is insertion of the needle. So now please pay attention carefully to this. At this point, when you are inserting, okay, the plunger is at uh, at the base. Okay, is at the base, and the needle is penetrating into the lesion. So here we are imagining that this orange is similar to a swelling. The step after that is there is negative pressure that is applied. Okay, you see the plunger has moved back, negative pressure that's applied, and while you apply negative pressure, the needle is moved around inside the lesion in a circular manner. Okay, this is done in order to be able to take representative cells from the lesion. Okay, and when you do this, the negative pressure is applied, and the next step is the plunger moves back to uh, to the base, and only then you withdraw the needle. Okay, now this is a very important step. Now these two steps are very important. The reason being that when you apply this negative pressure, we have to take care that the contents that we are trying to withdraw from the lesion do not come into the syringe. The reason being that if they come into the syringe, then it's no longer an FNAC, because the contents to put it back onto the slide are very difficult, and we lose contents or cellular contents that we are trying to biopsy over here. So the aim here is to collect the material in the hub of the needle. Okay, in the needle. That is our aim as part of this biopsy. Okay, so once you apply negative pressure, you swiftly move it inside the move the syringe inside the lesion, and then you bring the plunger back, and then you take out the needle from the lesion. Step after that is you disengage the needle. All right, you fill air into the syringe. All right, and then force the content out onto a glass slide. Okay, why do I say that this is an important step? Is because if you forget to disengage, that means if you forget to take out the needle while you are actually filling air in the syringe, then the contents again from the needle will get aspirated into the syringe, and you will not be able to transfer the material onto the glass slide. So that is how important and technique sensitive this biopsy procedure is. Okay, so this is how an FNAC is done, fine needle aspiration cytology. Okay, once the content is transferred onto the slide, you use another slide to apply pressure and move it move it to create the smear. Okay, so this is basically a one-step smear. The top far edge of the spreader slide is lowered onto the specimen droplet, and gentle pressure is used to flatten the material. And once it's flattened, it dries, and then it's stained, and it is examined under the microscope. So this is how an FNAC is done. So in summary, okay, I'm going to run through this again because as I mentioned, it's a very important and technique sensitive biopsy. All right, so number one is localization and stabilization. Okay, pierce the lesion using a 25 to 21 gauge needle, a 2.5 ml syringe. Okay, so you go in, right, you withdraw the plugger, creating a vacuum, right, 2 to 4 ml, and without exiting the lesion, redirect and fan the lesion. That is, direct the needle along a number of different tangents, right? That means you move it around inside the lesion while you are applying negative pressure, ensuring that the content does not come into the syringe, right? Next step is release the plugger, returning the vacuum to base or 0 ml. Exit the lesion. The step after that, detach the needle from the syringe, right? Fill the syringe with air. This is the most important step, as I told you. If we go wrong over here, that means we forget to take out the needle and fill air into it. All the content that we have collected, the cellular content, it will get stuck inside the syringe, and we will not be able to prepare the smear. All right. So we fill air into the syringe, connect the needle back, and then push the air out. When you push the air out, the contents come onto the slide, and thereafter you prepare the smear, and that's how an FNAC is done. All right. So very important learning messages here. Number one is a biopsy technique that's done only for swellings, usually done for extraordinary swellings. Okay, and it's a very technique sensitive biopsy procedure. Okay, right. So this is fine needle aspiration cytology. The difference between fine needle aspiration cytology and fine needle aspiration biopsy is the wider gauge of needle that is used for FNAB. Okay, right. So let's move on to the next biopsy technique, which you should know. All right, and this technique is called frozen section biopsy. Okay, now frozen section is a rapid tissue sectioning by cooling the tissue with the help of a cryostat to provide immediate report of a tissue sample. All right, the cryostat is an instrument to freeze the tissue and also to cut frozen tissue for microscopic section. All right, now this is an infographic over here. So if you see this gentleman over here, he is a pathologist. Okay, he is the procedure he's doing here is called a frozen section. Okay, so now this box shaped instrument that you actually see here is a diagrammatic representation of a cryostat. Now cryostat is a machine that can actually freeze tissue right up to minus 25 degrees centigrade. So the temperature that is maintained inside a cryostat is minus 25 degrees centigrade. Basically, a cryostat is like a super cool refrigerator which has a microtome inside it. I'm sure you guys all know that microtome is a device, an instrument that is actually used to section tissue to produce uh, histological slides and for basically biopsy examination. Okay, now frozen section. Okay, why do we need to actually do a frozen section, or where is this actually applied? Okay, a frozen section basically is instant freezing of tissue to be able to make it firm, to be able to section it to a certain extent, then to create a slide, stain it, and diagnose it. That's the aim. Okay, so now frozen sections are basically indicated for intraoperative diagnosis. That means, you know, at a regular play during a regular where do we use this? You know, this setup is usually quite is placed right next to the operation theater where our surgeon colleagues are doing a particular surgical procedure, and they need to know the diagnosis while they are doing uh, the procedure, so that it can direct their surgical treatment. That is where we do it. So that's why we call it intraoperative diagnosis. All right, so basically what happens is there is something called as a cryo embedding fluid that is used to basically freeze tissue. Okay, to freeze tissue, right? So as you all know, human tissue, okay, any part of the body is basically 96% water, and we cannot use water to freeze the tissue because we cannot section it once we freeze that. So there are commercially available specialized freezing medias, okay, which are used to freeze this piece of tissue instantly inside a cryostat. Okay, so here as you're seeing, the biopsy that has been removed by the surgeon is placed in the middle of the chuck. Okay, it is filled up with the cryo liquid, and then a chuck is placed over it. This entire procedure is happening at minus 25 degrees centigrade. So within a few seconds, what happens is the tissue freezes. All right, tissue freezes, and we have a block like this. Okay, now the fact that you guys have already learned about tissue processing, you will know that during regular tissue processing, what we do is basically, once the biopsy is done, you have that piece of tissue that goes into formalin, and then the tissue gets fixed, and then there's a whole processing that takes place wherein the water inside the tissues is replaced by by xylene, and then replaced by wax, and then we create something like a wax block which we use to actually section tissues. Okay, that's currently the the processing for biopsy that is done. Okay, now here, because we need instant diagnosis, we cannot go through that entire wax processing, and so we do something called as cryo embedding, which freezes the tissue at minus 25 degrees centigrade, making it firm enough to be able to go through sectioning. Okay, to be able to go through sectioning. Now this is how sectioning is done. All right, so this is the microtome. You have the block placed over there and the thin blade placed over here, and when the microtome is rotated, right, you get these thin sections. These sections are then immediately stained, and then intraoperative diagnosis is given to our surgeons. Okay, so indications for frozen section usually are intraoperative diagnosis, as I mentioned. Most commonly is something for like margins of tumor section. Okay, so for many of you who do not know what exactly margins of tumor section are, I would like to explain here. Let's imagine this to be the buccal mucosa. Okay, let's imagine this to be buccal mucosa here. Okay, I'm just trying to do this. Let's say there is a tumor over here. All right, let's say squamous cell carcinoma, which is being removed. Okay, so what generally happens is the surgeons leave a normal margin around the tumor. Okay, and then they take out this whole thing, so that the area is disease free. What happens is that you actually want to identify, despite the fact that physically we are able to see the tumor here, microscopically we could have tumor cells anywhere in this, even though it's looking normal, right? So what happens is when the surgeons remove this piece of tissue, they actually send each of this tumor margin, okay, anterior, superior, posterior, okay, inferior, okay, they send each of this to the pathologist in the next room to do a frozen section to be able to tell us that whether this is margin is free of tumor or no. Okay, so this is a great example of where frozen section is used. I hope you get that. If let's say the report says that no, these three margins are free but the anterior margin is not free, then what happens is they further resect more tissue so that eventually the treatment that they have done, surgical treatment that they are doing, ends up free of tumor margin. However, if we reach a point beyond which it cannot be resected because either there is a very important organ, an artery, or any other structure passing through that, what happens is that you leave behind tumor cells over there, and then that's the reason why post-operative radiotherapy is given specific to that site. Okay, this is a very broad general information that I'm trying to give you so that you understand the concept of frozen section over here. Okay, I hope this makes this clear. Right, so now coming to the most important learning outcome, all right, the most important learning outcome as to what do you submit, right? Now, as undergraduate students, as I mentioned, it's very important for you to be able to, uh, first of all, identify where biopsies are done, what types of biopsies are there to be able to describe them, then uh, to be able to fill out a biopsy form, okay, because as an undergraduate student, at PIDC or at any dental school, you will follow your lecturers as well as your seniors in when these procedures are done, and the first skill that you learn is to fill out content on a lab form that goes to the lab. Okay, and that is an important procedure. It's an important step that you learn. Okay, so what do you submit? So all tissues removed from the oral maxillofacial region except, okay, except teeth without soft tissue. That means regular extractions that are done in which there is no periapical tissue that is found attached to the root surface. We do not need to submit that. Second, extirpated pulp tissue. Now, extirpated pulp tissue is tissue that is removed when RCTs are done. Okay. Now, the reason this tissue, although it's human tissue that is being removed, we do not submit for biopsies is because evidence as until now does not show any metastatic diseases that come to the pulp or any major uh, diseases, life-threatening diseases that can occur inside pulp tissue. All right. The third type of tissue that we do not submit for biopsy is clinically normal tissue. Okay, so if you are doing if you are doing a procedure and you cut out normal tissue for some reason, you do not submit that for biopsy. Okay, and the last is excess donor tissue from grafting procedures. Okay, so if you are doing a grafting procedure, let's say a periodontal grafting procedure, you take a um, donor tissue from the palate and then you suture it, but there is additional graft material, tissue that is left, we do not submit it. Okay, all other tissues, when you submit a biopsy, you will have something like a requisition form that needs to be submitted. Okay, now when this requisition form has to be filled out by the operator or the assistant, many times when you're assisting, you would be helping out the operator to fill it up. Okay, at the dental school, the operator is usually the lecturer and you are observing and assisting on most of these procedures. Okay, but you sure help out in filling out this. Now, filling this out is very important. Why do I say it's very important is because if you mix this up, okay, let's say there are two procedures of biopsies that are done and then you mix patient information, it has a huge impact. It has a huge impact on the treatment. It has a huge impact on what is going to be conveyed to the patient. Okay, imagine If you do that between a benign lesion and a malignant lesion, it could be disastrous. All right. So as a student, it's important to copy down this information very clearly and write it down in the designated space. Okay, so patient information is what generally goes into the requisition form. Who is the submitting doctor? What is the patient identification number? Most important, what is the site of biopsy? You would have to write it down. This is an example of one of the forms that I got from the internet. Okay, we do have a similar form for biopsies that are done at PIDC as well. You can look it up and inside the patient file. Okay, and you mark the site. Let's say you're doing it on the buccal mucosa, and then mark that site. You have to give a clinical description of what was the lesion, what are the complaints that the patient came up with, and a very important part is the clinical differential diagnosis, because you have to understand that this sheet of paper, okay, acts as the your eyes for the clinical picture for the pathologist who does not see the patient. Okay, the pathologist only sees the glass slide which comes from processing of this biopsy tissue, but to be able to think what you were thinking when you did the biopsy, it gets conveyed to the pathologist only through this requisition form. Right, so it's very important to fill out the site, fill out the clinical details, fill out the clinical differential diagnosis, and mention what type of biopsy was it. Was it an incisional biopsy? Was it an excisional biopsy? If it was an incisional biopsy, what was the instrument that was used? Whether it was a punch biopsy, whether it was a scalpel biopsy, so on and so forth. Okay, so this is how you are required to fill up the requisition form. Okay, so this brings us to the end of the topic on biopsy. I hope you've understood the core concepts over here, and please go back and feel free to go through the lecture again, and if you have any queries, send me an email, or you can ask your questions on the Google Classroom that has already been initiated. Right, so thank you very much. Have a nice day.